Gyan comes back for AV blocks.
Thank you, sir. Now we move on to the session of TAC and bradyarrhythmias. We are now called Dr. Gyan Ranjan sir for his talk.
So without any further delay, we will go to my second talk, that is discussion on AV blocks. So I will be specifically talking on AV blocks. Okay. So for AV block, you should be knowing that in the ECG, there would be we will be looking at the P wave, the PR interval, and the QRS. Okay. So there is a story before I start.
Gyan, just 1 second.
Yes.
If any of you feel that we are going fast and you do not have time for questions, please put it on the crystal group. I'll make sure that those people answer it. If you feel that we do not have time between talks, you can put it on the group Crystal 2023. You have been allowed to put your comments. We can answer those questions if you have any doubt. Sorry, please go on.
Yeah. So there was this couple, okay, a husband and a wife. So the husband goes out. Nor there is a first I would give an example of a good husband. Okay, he comes home at 7 o'clock sharp after the duty is over. Okay, so there is no delay. Every time by fail he comes at 7 o'clock. Then there is another kind of husband who will always go some out, have some party and come at 9 o'clock. But daily he will come at 9 o'clock. He should have come at 7 o'clock. But daily he will unnecessarily will delay by 2 hours. So the wife gets angry. Okay. So there is a third type of husband. So what he will do? One day he will come at 8 o'clock. One day he will come at 9 o'clock. One day he will come at 10 o'clock. And one day he doesn't come. Okay. So this is the third type of husband. So who do you feel whose wife will be more angry? This. Okay. But you are not listening. There is also a fourth type. Okay. So that fourth type of husband, he will come daily at 7 o'clock. But sometimes on Monday or Tuesday he will not come. You don't know when he will not come. The wife also can predict when my husband will not come. So what do you think? Who will be more angrier? This fellow's wife, na? Because sometimes he will come at 7 o'clock. Tomorrow, the wife doesn't know whether he will be coming or not. Okay. Then there is the last, after getting angrier and angrier, they file divorce. Okay. So the husband says, okay, I am going on my way. The wife says, okay, you don't come. I am also going. Okay. So they were there now. So this is the story of AV blocks. Okay. So first husband is like second husband. That is the first degree AV block. Okay. So he comes late. That is the AV conduction will be delayed, but it will eventually reach the ventricle. So there will be a 1:1 conduction. Okay. There will be no drop in the beat. So it is defined by the PR interval more than 200 millisecond, which is 5 small squares. But this delay is without interruption in conduction from atria to ventricle. Okay. Only the PR is prolonged, nothing else. Okay. So you should know the causes of this first degree AV block. What is the most common cause is increased vagal tone, mostly in children's or in elderly or athletes. And it can be also seen in inferior valve MI, which I already discussed. Some surgeries, some inflammations, myocarditis, Lyme's disease, and you should also know common causes like drugs and electrolyte abnormalities. Most commonly, as you have posted in CCU, you've been knowing lot of patients would be having hyperkalemia. We'll see there is increased PR interval, and also the patients on beta blockers will be sometimes having first degree AV block. Okay, and it can also be a normal variant. So what should we do? So mostly no specific treatment is required. If there is a cause, if there is the patient is taking beta blocker, you can decrease the dose. If there is hyperkalemia, you can correct it. So you can see over here. Okay, so you can see this ECG. So what do you see? So here you can see this T wave, and there is a notching over this T wave. So first you see where is the P wave. So this P is actually on T. Okay. So you can see over here, here. So this T is notched, means the P is merging in the T, means the PR is prolonged. But the PR is prolonged in similarly in all areas. Okay. It is constant. It is more than 300, but it is buried. Always look at the T wave morphology in any ECG. Okay. And you can also see over here here also the PR is prolonged. So this is a fast degree AV block. Okay. Again, this ECG, again, you can see that after the T starts, the P comes and the PR is prolonged. Okay, again, it is a first degree AV block. So that is, then we'll be talking about the third type of husband who will today come at 7, then 8, then 9, and suddenly one day he will not appear. That is the Morbid's 1 or the second degree AV block, which is classified into Morbid's 1 and the Morbid's 2. Morbid's 1 is called also as the Wenke-Beck phenomena. There would be progressive prolongation of the PR interval. And lastly, there would be a non-conducted P waves. One, there will be in your first degree AV block, the conduction is 1:1 without fail. Okay, but here eventually one P wave will be dropped. Okay, so PR interval will be so PR interval will be gradually increase, and you can see here there is PR again. It is increasing, and here this P is not followed by QRS. Okay, and again normal P followed by QRS and T. So you remember this ECG. Okay, so PR interval is shortest immediately after the drop bit. So here this is drop bit. See this PR and this PR. Which one is longer? So this PR is longer than this PR. But if the examiner asks which is the PR which has the most prolongation, it is usually the first or the second bit. Okay, so there is a catch. If somebody asks which is the longest PR interval, definitely before the drop bit. But which has the most increase in the PR length, then it is the first and the second. Okay, so the PR increases, the RR decreases. So if you take a long strip, what will happen is the RR decreases and there would be a group beating. Okay, this group beating is important. Okay, you will see because the PR increases, but the increase is not equal. The increase is highest in the first and second bit. But if which is the most prolonged PR interval, definitely before the drop P wave. So this point you have to remember. They can frame two types of questions in this only. So don't get confused. So what are the causes of Wenke-Beck? Again, drugs, even in sleeps like vagal tone, you can see, you can do Holter, regularly, and you can see some patients in deep sleep would be having Wenke-Beck. Okay, that is not abnormal. In inferior valve MI, that can have a variety of presentation in myocarditis and also following some cardiac surgeries. So the PP, so you have to in AV blocks, you have to see the PP, see the PR interval, see the RR interval. Okay, these three you have to see. So PP interval remains constant. And as I have already told, greatest increase in PR interval is typically between the first and the second bits of the cycle. The RR progressively shortens with each bit of the cycle. Okay, so it can be 3:2, 4:3, or 5:4. Okay. So what is the prognosis? Mostly it is a good prognosis because mostly they are due to reversible conduction block at the level of the AV node. So remember, first two husbands, that is the first degree AV block and the Morbid's type 1, they are typically above His. So when we are talking of AV blocks, we categorize as suprahis and infrahis. Okay, suprahis are usually the first degree and the Wenke-Beck. They have good prognosis, usually don't need pacemakers. But after the Morbid's type 2 and complete AV block, mostly they are infrahis. So they have great prognosis. Okay, so as I have already told, it is a benign rhythm and cause minimal hemodynamic disturbance. Okay, and asymptomatic patients do not require treatment and mostly they respond to atropine. Okay, so any suprahis pathology, if you give atropine or exercise, they will improve. Any infrahis pathology, if you give atropine or exercise, they will worsen. You have to remember this line. Okay, so permanent pacing, is it required? No, because they will revert on its own. You can see over here. See you can see PR prolonged, and here there is P drop. Again PR prolong, and here there is P drop. Okay, So this is the classical Mobitz type 1 AV block. Okay. I've already told this. So this is, you can see there is ST elevation. So can anybody tell which MI is this? Inferior wall MI. What is the culprit? I have just talked it. Forgot everything. So 3 more than 2, 1 AVL depression. So it is RCA. Okay. So here you can see there is so I'm going to this ECG, interesting ECG. So you can see there is some atrial spikes over here. See, there is one spike, there is one spike, here one spike, here one spike, but you can see every time the PR interval prolongs, and but over here there is drop. So we give atrial pacing and we generate an Wenke-Back phenomena. Okay, so is it abnormal? No, it is normal, because the property of the AV node will not allow impulse to pass after a certain rate. So God has made AV node so that your impulses rate, if the atria beats like 160, 170, you cannot allow all the impulse to pass through the ventricle. Otherwise, the ventricle rate will go to 160, 170. So while atrial pacing, you can see a Wenke-Back phenomena. Okay. Then coming to the more grievous types, that is the second degree AV block with the Mobitz type 2. Okay, it is also called as Hayes block. And what is it? Suprahis or infrahis? Anybody? Very good. Infrahis. Okay, it can be infrahis or also it can be intrahis within the his. Okay, so for you, you have to remember it is not suprahis. Okay, rarely suprahis. Okay, so these are very poor prognosis. Mostly they have hemodynamic decompensation. Okay, you have, when you see this ECG, you have to be very careful. Then this is that fourth husband who sometimes comes. Today he will come, tomorrow he will not come. But whenever he comes at the same time, 7 o'clock. So there will be fixed PR. Okay, here there is no prolongation in PR. The catch is the PR never increases. Okay, the PR is fixed. Okay, PR is fixed. There is no prolongation, but there will be sudden drop. You see, here there is PQRST, PQRST, PQRST. Then suddenly P is not conducted. Okay, then again there is a PQRST. Okay, so this is Mobitz type 2. So the PR interval in the conducted beats remains constant and the P wave is marching at a same rate. So P, you can see this P, all are constant. Okay. So the RR interval surrounding the drop beats, if you can see this R to R interval is exactly the multiple of the RR interval preceding it. If there is one block P wave, then it would be multiple twice of this. If there is two P wave, again it will triple for that. If there is two blocked P waves, then the RR interval is triple of the previous RR interval. Okay.
Okay, let me ask you, all of you. Suppose you do exercise on this patient, what do you expect?
This patient, what happens? What happens to the rate?
I already told you.
Atrial rate will go up. What will happen to the ventricular rate?
What you feel on your pulse is the eventual ventricular rate. What happens?
So I told you with atropine and exercise, if it improves, then it is suprahis. If it worsens, if the heart rate doesn't improve, then mostly it is infrahis. So sir was asking that question. So Mobitz type 2 is suprahis or infrahis? So what will happen to the heart rate? It will not increase or decrease. Okay.
You have a disease conduction system. Earlier you had 50 impulses coming. Now you have 100 coming. If it's already diseased, you're trying to flog a tired horse. Even that will not come. Understand? It's basically a disease of the infrahisian, as I said, conduction system. This is asked you in exams. Okay. Sorry.
So as I told, Mobitz type 1 is due to functional suppression of AV conduction due to electrolytes, due to drugs. But Mobitz type 2 is mostly, as sir told, it is structural damage to the conduction system. might be due to MI, interval MI, fibrosis, necrosis, or might be due to some procedures, or might be due to some myocarditis causing necrosis of the bundle branch. Okay, or it could be pre-existing LBB or bifascicular block and intermittent failure of the remaining fascicles. Mostly it would be a bifascicular or trifascicular block, bifascicular block, and intermittently the one fascicle which was conducting suddenly doesn't conduct, leading into Mobitz type 2. The prognosis is poor, and again infrahis pathology, as I will tell you later, mostly the QRS is broad. Remember this, okay? Suprahis QRS will be narrow. Infrahis QRS will be broad. For you, you have to understand and you should remember this, okay? So what happens in the complete heart block? The QRS will narrow or broad. It is infrahis, no? So mostly it will be broad. I will be telling about it later. So causes, as I have already told, mostly structural diseases, interval MI or fibrosis, or any cardiac surgery or inflammatory conditions like myocarditis, rheumatic fever, or infiltrative heart diseases like sarcoidosis or amyloidosis. Yes, it is never physiological. Okay. So as I've already told, it mandates immediate admission for cardiac monitoring. If you see this ECG, you should not send back the patient if he is symptomatic. Okay. Because the risk of asystole is around 30% per year. Now coming to this fixed ratio AB block. So that it can be this second degree fixed ratio AB block, that is with a fixed ratio P wave, that is 2:1, 3:1, or 4:1. So mostly many people think that 2:1 means Mobitz type 2. No, it is not right. It can be Mobitz type 1 or Mobitz type 2. So you can see over here PQRST. Here P is not conducted, PQRST, P not conducted, PQRST, P not conducted. So it is a 2:1 AB block. 2P and then 1 QRS. 2P, 1 QRS. Okay. So what we have to see what is the arterial rate. I told you always see the PP, the RR and the PR. Okay. So here the arterial rate is around 75. The ventricular rate is around 38. So you can see this non-conducted P waves. And here we can see the same thing. It is a 3:1. Why? So P, you can see this always remember, always see these T waves, because the P waves always get merged into this. If you don't really pay attention these T waves, you can miss a hidden P wave inside it. Okay. So actually this is P. So 3:1 AV block. Okay. So here we can see there is a 4:1 AV block. Here see this T is tall because it is a P wave buried inside it. Okay. So 1, 2, 3, 4 P with 1 QRS. So that is 4:1 AV block. These are high grade AV block. So what is the high grade AV block? So any block which is 3 or 1 or higher, 3:1 or higher is called a high grade AV block. So, and they can be, don't think that it is Mobitz. We are not talking about Mobitz anymore. We are talking about pure high grade AV block. It can be Mobitz 1, can be Mobitz 2. They have their specific definition. You have to know that. Okay. So okay. So last I will be talking about complete heart block. So in complete heart block, you have to see three things. So you have to see the P interval. So here it is the last husband who is worst. The husband is going somewhere, the wife is going somewhere. That is, the P is beating at a separate rate. The R is beating, the ventricle is beating at a separate rate. They are independent of each other. There is no conducted your impulse from the atria to ventricle, no conducted your impulse. Okay, so the P, you can see the PP is beating at a separate rate, the RR is beating at a separate rate, but see the PR. It is the most important thing. The PR is varying. Okay, so this is complete heart block where the PP is beat separately. There is RR beat separately and PR varies. So one thing you have to know in complete heart block is what is the escape rhythm, because the impulse is not coming below the ventricle or the junction takes over. Okay, so you have to see the escape rhythm. If the escape rhythm is 40 or above, it is called as a junctional rhythm. If it is less than 40, it is mostly ventricular rhythm, 20 to 40. So more below, more grave is the prognosis. If the escape rhythm is good and the escape QRS complex is narrow, then the prognosis is good. Mostly he might not require a pacemaker. But if the escape rhythm is wide and the escape rate is less than 40, that is 20 to 30, then he might be needing a pacemaker. So you can see over here. So you can see PP and PR interval are varying and RR is constant, PP is constant, PR is varying. So this is AV dissociation. Also here you can see P, and after long time there is QRS which is wide and the escape rate is below 40. It is something like 15 to 20. Okay, so very poor prognosis. These patients would be needing your permanent pacemaker. I think I will stop it, sir. Or
Okay,
should I-
I'll ask a simple question before you leave. What do you mean by PR interval? Where does the impulse go from where to where? You want to tell us? Pick up this. Who knows? What is PR interval? What do you mean by that?
What causes the PR delay? What is PR intervals?
From where to where?
From SA node to wrong. That's the point I was trying to tell you. That's the common understanding. It starts from P to R, from atrium, from the SA to no, it's not. And sir will tell you why. He's just spoken about it.
Just now you heard all the whole Ramayana. Now you
Questions which are asked and which are actually made of the mistake. That's why he was stressing on that. It's nodal delay. It's not SA node to AV node. It is nodal delay. It hardly takes time for the interatrial conduction, intraatrial conduction. Understand? AV node is the one where it happens. It is nodal. He told it so many times. It's nodal.
the
It's not-
PR interval is divided into two parts, AH interval and HB interval. So that is part of the PR interval. So that means from SA node to AV node to Purkinje fiber. That is PR interval. They ask you, you should be able to tell this answer correctly. Don't say SA node to AV node. Okay, divided into two parts. Okay.
It's a great talk, Gyan. Again. Thank you so much. Some things that you need to know is in CAD patients commonly that you see, where do you get PR prolongation normally? If patients are on beta blockers, which I think most patients are on, then he spoke about Venkeback. Venkeback is asked, okay, which is, I think, very nicely described. If you are in an EP unit, if you have some hospital where your exams are going to be like Narayana has got a strong EP unit, Jaydeva has, so they might ask you things about what sir asked you, AH, HV intervals. Of course, Anand will be alluding to the pacemaker part also. And you could be asked about pre-excitations. Okay, this was something which has not been like covered. It's not possible to cover everything. You can be asked about pre-excitations, how they can change your patterns of ECG. And when it comes to echoes, when you see a patient with aortic stenosis, calcific AS, always remember that that can track down into the fibrosing system. So you might be having a patient who can need a pacemaker after the surgery if it tracks down. And one thing I think I didn't allow him to complete because of time, but then he would have spoken about it anyway. CHP, can it be narrow complex? Can CHP have a narrow complex QRS? Yes, it can, particularly if it is congenital. So the rate will be better. What he was saying, junctional. So in those, the rate is actually better. You need not have CHB always broad complex. You can have a narrow complex QRS. If it is congenital, you will have P and QRS dissociated, but the QRS is narrow. This is asked. This was asked in one of the practicals last year. I think any more questions are there, we can always answer on the WhatsApp group. Yeah, please go ahead.
Thank you, sir. Now, I would like to introduce the next speaker of the session, Sir Anand M., proprietor of the Tech Medical Services. Sir has completed his Bachelor of Science in Bangalore University, and Sir has been certified with the IBHRE and CCDS. Sir has been worked in the Andromed Healthcare, and Sir has worked for the About as a service team head of Karnataka and a trainer at the About. I welcome you, sir.
In that I was just discussing with Anand also this time. There was this paper which was, I mean, we had this question in this last exam paper where it was mentioned about what are the parameters that you see in pacemaker programming. This came for the last question paper, right? For your paper. And this, I found 90% of students, I and ma'am have collected the papers. 90% of students have written how a pacemaker is done. The cleaning of axilla, this, that. That's not what we want. Parameters, the question was very specific. It's parameters. You have to know about impedance. You have to know about threshold. You have to know about what is sensitivity, what is yaw, what is lie, whatever. So the thing is, it's about a pacemaker. So some institutes which do not have exposure to it, this is particularly for them. Anand, I'm sure you'll do a great job. All the best.
Thank you, sir. Good morning. So today I'm going to talk about programming, pacemaker programming. It's very interesting topic and it's very easy topic though. And okay, so now we know where we have to give a pacemaker, right patient, right time and right indication, and strong evidence. We need to choose strong evidence to give a pacemaker to the patients, right? And up. So yeah, thank you. So when you give a pacemaker to the patient, it's not that it will not stop us, it will not end our job. So we need to take care of the patients in terms like regular follow-ups. It's very, very important. It's very, very important. That is our primary job, to take care of our pacemaker patients. It's critical and it's very easy. And technology, people think that pacemaker technology is very tough, but it's not at all tough. It's very easy. And I can say it is simple science, right? So let me go through some few slides. I have very short time, 15 minutes for me. So so stop me wherever you have the doubt, suppose. Okay, so importance of pacemaker programming. So we required a programmer to interrogate a pacemaker, right? So you can see there's a pacemaker, there's a band that we'll call it as RF telemetry band. Keep it on the pacemaker and then interrogate. So this will communicate from pacemaker to the programmer, whereas easily we can alter the parameters. We can change as physician suggestion. So whatever the required parameters can be changed. So, okay, what is our benefits? I mean, when you do the programming to improve our long-term outcome of patient pacemaker therapy, periodical follow-up is very, very important, as I told you, and to avoid re-hospitalization and redo procedures can be avoided, right? It's all in our hand. And patient safety and may increase battery longevity. If the patient is not coming to you after pacemaker implantation, it's very difficult. Pacemaker, whatever you have programmed, the higher voltage and all that, so it can drain pacemaker battery within 5 years or 4 years, or maybe even less also. So during the follow-ups, we can analyze where the parameter need to be changed, and accordingly we can do the needful for the patient. So we can increase the battery longevity also. And also the critical part is it can go loss of capture, over sensing. There are a lot of things which we are going to discuss further. That is going to be a patient safety. So what do you see here in this image? The single chamber pacemaker, which is VVI and VVIR, we will say that. So we will talk about that modes, what is VVI and what is VVIR as simple. So what we can see in the image, one lead, it goes into the ventricular chamber. So we will drop a lead in a ventricular chamber and we will pace from the ventricular right ventricular chamber, that we will say that VVI pacemaker or VVIR pacemaker. So let me rush quickly. So this is dual chamber pacemaker, which is DDD and DDDR, where it will maintain AV synchrony, that is DDDR pacemaker or DDD pacemaker, but definitely not single chamber pacemaker cannot be maintain the AV synchrony. and it's required 2 leads, one for RV, one for RA. So maintain AV synchrony. It maintains AV synchrony. AV synchrony, it will gives what? It is physiological AV synchrony. I mean to say, so natural pacemaker is dual chamber channel, right? Dual P wave followed by QRS. Here also, when you give a dual chamber pacemaker therapy to the patient, you can have really AV synchrony. Suppose I mean P wave followed by QRS, you can achieve. And also you can program a lot of parameters, heavy, delay, it's all in our hand. So what kind of parameters we need to program, how